Pleasant good afternoon or good evening to everybody, depending on what part of the globe you are in. It is my pleasure to welcome you to the Council of Affiliated Menopause Societies, the CAMS Menopause Hour. So this is an activity spearheaded by the International Menopause Society. For today, it is collaboration with the Philippine Society of Climacteric Medicine. Okay. So for today's webinar, the topic will be on transgender and the menopause. I am Dr. Maria Jesusa Banal-Silao. I'm the current president of the Philippine Society of Climacteric Medicine. And it is such an honor for me to be the moderator for today's webinar. So in this day and age, we are now having this growing special population of patients, that is the transverse and the gender diverse adults. And to be honest, there is a scarcity of information, especially in our country. That is why this is such an exciting topic for us. And we are honored to have prominent speakers. So from Australia, we have Dr. Brendan Nolan, who will discuss with us the transgender health and the impact of aging and menopause. And our local speaker, Dr. Zedric Galito, will discuss the challenges in the care of the midlife gender diverse population. Okay. Before we start the webinar, we would like to inform everybody that this online event has been supported by an unrestricted grant from Abbott. Nevertheless, Abbott had no role in the selection of topics or speakers and has not vetted or reviewed the content of the speaker's presentation. Please visit the IMS website to find out more about the many educational events and resources that you see listed here and about how to become an IMS member. Many resources are available for free, including exclusive offers for IMS members, free 1-year IMS membership upon completion of the Impart Level 1, IMS membership offers in partnership with local or regional societies who are members of CAMS, and monthly live events and extensive library of educational resources. Before we start, I would also like to inform everybody that this webinar will be recorded and will be available shortly through the IMS website. So to start it off, I would like to introduce our first speaker. Our first speaker is Dr. Brendan Nolan. He is an endocrinologist at Princess Alexandra Hospital in Brisbane and a research fellow in the Trans Health Research Group of the University of Melbourne. Dr. Nolan's PhD evaluated the safety and efficacy of gender-affirming hormone therapy for transgender and gender-diverse individuals. He continues postdoctoral research evaluating optimal gender-affirming hormone therapy with funding from the Royal Australasian College of Physicians Endocrine Society of Australia Research Establishment Fellowship and an NHMRC Investigator Grant. To discuss transgender health and the impact of aging and menopause, let us all welcome to the virtual floor, Dr. Brendan Nolan.
Thank you for the introduction. So today, I'm firstly just going to start with some definitions about transgender and then focus more on the impact of gender-affirming hormone therapy and aging. So just for some initial definitions, so transgender or trans people are people whose gender identity is different from their sex recorded at birth. And that can include people with binary gender identities, so that is someone who identifies as male or female, or non-binary gender identities. And we're seeing an increasing proportion in Australia of people who identify neither with the male or female identity, but instead acknowledging that there is a spectrum between. So, and just to draw your attention to the figure on the right of the slide, within our clinics, almost or just so over a quarter of people identify as non-binary. About a third of people identify as a transgender man, so that is somebody who was recorded female at birth, but with a male gender identity. and about 40% identify as a transgender woman. So that is someone recording male at birth, but with a female gender identity. And so there have been several population-based studies that have looked to evaluate the prevalence of gender diversity. And you can see the population-based estimates are usually somewhere between about 1 and 4% of the population. But really what we've seen probably about 10 years ago was an exponential increase in demand for gender-affirming hormone therapy services. So the figure on the left of the slide here comes from a single endocrine clinic within Melbourne, Australia. And you can appreciate from about 2014, there was a quite significant increase in demand for gender-affirming hormone therapy. We have more recent unpublished data that demonstrates that that's actually plateaued more recently. And really the rise in demand is not, the reasons are not particularly clear, but we hypothesize that it's probably likely that it's due to the increased visibility of trans people, access to more information, particularly more information online, overall reduced stigma, but also an increase in the number of services providing gender-affirming hormone therapy. And I think it's just important to note as well that the trans community do have alarming rates of mental health comorbidities compared to the general population. So the data on the slide here come from a national Australian survey of about 1,000 trans Australian adults. And you can see that the numbers are quite alarming, with about 3/4 reporting a history of depression, 2/3 a history of anxiety, over 60% report a history of self-harm, and nearly half report a previous suicide attempt. And these numbers are far higher than other populations within our group. Part of this is likely due to discrimination that many trans people are facing. And I've just listed again some of the potential factors that lead to some of these mental health comorbidities. And we know that there are a lot of barriers to healthcare within the trans population, high rates of mental health comorbidities, abuse and discrimination from the general population, difficulty accessing basic medical care and gender-affirming care often due to a lack of doctors just not being trained in trans healthcare. And ultimately, there is a lack of research guiding our gender-affirming care as well. So now going to move on to gender-affirming hormone therapy. Firstly, testosterone. So with testosterone, our general aim is to increase the serum testosterone concentration to within the cisgender male reference range. And as you can see, this is highly effective at inducing masculinization. Within Australia, the intramuscular testosterone formulations are most commonly prescribed. We have the long-acting testosterone undecanoate as the most commonly prescribed formulation, but also have access to testosterone enantate or other testosterone esters. We also have access to transdermal testosterone formulations such as creams and gels, and previously also prescribed patches or oral testosterone, though these are less commonly prescribed now. Testosterone induces several physical changes. We counsel people regarding male pattern baldness, changes to facial shape, deepening of the voice, which is a permanent physical change with testosterone, and development of facial hair and body hair. Changes to body fat redistribution and increases in muscle mass can start early within 3 to 6 months, and then often extend out to 12 to 24 months. We see an increase in bone density in some trans people treated with testosterone. People achieve menstrual cessation, typically somewhere between 1 and 6 months after initiation of testosterone. And we counsel regarding the risk of polycythemia, which is the most common adverse effect with testosterone and occurs probably in about 1 in 6 to 1 in 10 people, depending on the testosterone formulation. Feminizing or estradiol-based hormone therapy, on the other hand, typically encompasses two medications. So there will be estradiol. Again, our aim with estradiol is to increase the serum estradiol concentration to within the cisgender female reference range. This is most commonly achieved with oral estradiol, and we most prescribe oral estradiol valerate. We also have access to twice-weekly patches or daily estradiol gel. Following initiation of estradiol, we typically also see a decrease in the serum testosterone concentration. However, that is often not sufficient to get the testosterone concentration to within the cisgender female reference range. And as such, we typically add an anti-androgen. Within Australia, we most commonly prescribe spironolactone at doses of 100 to 200 milligrams daily, and I most commonly will commence 50 to 100 milligrams daily of spironolactone, or ceproterone acetate. And we're, due to the, evolving literature demonstrating associations with ceproterone acetate and meningioma, we're now prescribing much lower doses. And I'll often initiate doses of 25 or 12.5 milligrams twice a week to mitigate this risk. Again, feminizing hormone therapy causes characteristic physical changes. People will get changes to fat distribution, including fat distribution within the face. And it's important to note that voice does not change with feminizing hormone therapy, and as such, we recommend speech pathology. People will note a decrease in facial hair, softer skin, and changes to body fat and muscle mass. So people would typically get an increase in the gynoid fat area and reduction in muscle mass. Some studies demonstrate a reduction in bone density with feminizing hormone therapy, and I'll take you through some of that data today. One of the most desired physical changes for many patients is breast development, and that often will commence within a few months of initiation of hormone therapy, and reduction in sexual function is often important for many of our patients. So just to focus on adverse effects, and I guess this will kind of frame some of the next few slides of the presentation. Firstly, with masculinizing hormone therapy, polycythemia is one of the most common adverse effects. And I'll really be focusing today on cardiovascular disease. With feminizing hormone therapy, again, I'll take you through some of the data evaluating cardiovascular disease and thromboembolic disease, and also look at some of the data regarding compromised bone structure. So a lot of our data regarding cardiovascular disease and venous thromboembolic events come from large cohort studies from the United States and Europe. And importantly, some of the earliest studies from the 1980s, 1990s did report relatively high risk of thrombosis. However, as you can see with some of the more recent publications, VTE risk is actually relatively low, particularly in people with transdermal estradiol. It's important to note that apart from hormone therapy, there are several other factors that can increase VTE risk. Ethinyl estradiol is associated with VTE risk, and as such, we don't prescribe that, and it's not recommended in any of our current guidelines. And there are obviously other factors that are very well known to be associated with VTE risk. Some of the large cohort studies from America, and the data on the left of the slide are from the United States, have evaluated the risk of venous thromboembolism, stroke, and myocardial infarction compared to reference populations of cisgender men and women. And just to highlight firstly that feminizing hormone therapy has been associated with an increased risk of venous thromboembolic disease compared to both reference male and female populations. And trans women also have a higher risk of stroke and myocardial infarction compared to the general female population. Similar data were seen from the Amsterdam clinic. Again, a lot of this mirrored the findings of the United States data, other than perhaps an increased risk of stroke in trans women compared to a reference population of men, and also a higher risk of myocardial infarction in transgender men. I'll now move on to bone health. There's very limited data evaluating fracture risk in the trans population. And this data is a nationwide cohort study from the Netherlands, in which they had approximately 1,000 transgender women aged 50 years or less, 1,000 trans women aged 50 years or greater, and about 1,000 trans men. And they compared these people to a reference population of 5 men and women from the general population. And it's important to note, though, that even though they're looking at fracture data, they got the data from emergency department visits. So these were not necessarily minimal trauma fractures. What you can see is in the trans women older than 50 years or greater, they had a significantly higher risk of fracture compared to control men. And in trans men, there was a lower risk of fracture compared to control men. So perhaps the group of people that we should be worried about are trans women on feminizing hormone therapy. Risk of fracture. However, there's actually data that demonstrates that trans women have lower bone density at baseline compared to the general male population. The data here is from a single study, again, from a European cohort, that demonstrates that at baseline, so even prior to initiation of gender-affirming hormone therapy, you can appreciate that their lumbar spine Z-score was lower than a male reference population. And these findings have subsequently been replicated in a number of other studies, including both trans youth and trans adults. And it's hypothesized that this could be related to lifestyle factors, so potentially lower rates of physical activity, as well as greater social isolation could be contributing to this difference in risk. Feminizing hormone therapy, as we know, sex steroids are important regulators of bone remodeling, and perhaps this will be part of the answer. Again, long-term data from the Amsterdam cohort. In here, they had 10 years of follow-up and looked at DEXA at initiation and then up to 10 years after initiation of gender-affirming hormone therapy. And I just really want to highlight that the people who had the greatest loss of bone density were transgender women who had the lowest serum estradiol concentrations. So when they split the cohort into tertiles, it was the people in the lowest tertile who had the loss of aerial bone mineral density. And so based on this data, we now recommend, at least from a bone health perspective, that people's serum estradiol concentration should be above at least 182 picomole per litre, and perhaps even higher, because you can see those with the greatest serum estradiol concentrations had improvements in bone density. This group also had the highest rate of bone remodeling markers, so markers of bone loss. And so perhaps in a transgender woman, it's likely that there are suboptimal lifestyle factors that contribute to this risk. And perhaps trans women don't achieve peak bone mass. And so really, in an absence of data otherwise, and there's currently no data evaluating anti-resorptive or anabolic therapy in this cohort, generally our recommendations are to ensure smoking cessation, optimizing serum vitamin D concentrations, giving recommendations for regular weight-bearing exercise, and obviously also ensuring adequate serum estradiol concentrations. So moving on to menopause, and I'd just like to acknowledge firstly that there's really a lack of data in this area in the trans population. And there are differences between trans people and cisgender populations with respect to menopause, particularly with people treated, well, with both estradiol and testosterone-based hormone therapy, as it's unlikely that many people will stop feminizing or masculinizing hormone therapy at the age of a standard menopause. This was a study that enrolled 67 trans women, and you can appreciate that most were taking gender-affirming hormone therapy. And it's just really important to note that they thought that the views of menopause were different to the general population and really didn't necessarily think it was relevant to them, as most expected to continue to use gender-affirming hormone therapy indefinitely. But perhaps one of the changes that will occur, and one of the changes that's recommended in several consensus guidelines, is changing the formulation of estradiol. So obviously we know from the menopausal hormone therapy literature that transdermal estradiol is not associated with an increased risk of venous thromboembolism. However, there's clear data that shows that escalating estradiol dose is associated with venous thromboembolic events. And so based on this, and knowing that we typically treat transgender women with higher doses of oral estradiol, perhaps as people age, we should actually be looking at changing their estradiol from an oral to a transdermal formulation. There's really a lack of data in this area. A few years ago, we looked at our clinic data of about 300 people on estrogen-based hormone therapy, and I'll take you through that. With masculinizing hormone therapy, there's no real data to guide us. And so really, most people in my clinics would usually continue testosterone, and most people prefer to continue intramuscular testosterone. So within our cohort, we stratified our cohort into people less than 45 years, or 45 years or greater. And the reason for that is that there are some guidelines that recommend changing to transdermal estradiol at that age. Firstly, I just want to highlight that oral estradiol dose was lower in the older age group. So perhaps we were offering a lower dose to people at a high risk of venous thromboembolism. However, when you actually look at the data, you can appreciate still only a small proportion of people were treated with transdermal estradiol. However, that was significantly higher in that older cohort. The serum estradiol concentration achieved was similar between groups though. And this is just showing the serum estradiol concentration stratified between groups, where the older group are people in the blue on the left. We also looked at cardiovascular disease risk factors, and you can appreciate there were relatively high rates of hypertension and smoking in our cohort. There were only a small number of cardiovascular events though. And when we compared the data to the general population, you can appreciate that there were higher rates of hypertension and smoking, as well as dyslipidemia. And so really, other than the recommendations in consensus guidelines, there really were limited data evaluating transdermal estradiol. But based on the extrapolations from the menopausal hormone therapy literature, we still recommend transdermal estradiol. And really, I guess the other thing is noting the high rates of modifiable risk factors, and it's important to mitigate the risk of cardiovascular disease. And so in my cohort, I typically check all of their cardiovascular risk factors on at least an annual basis. And so just for the sake of time, just as a summary, I think gender-affirming hormone therapy is typically given to achieve serum estradiol and testosterone concentrations in the respective reference ranges for the affirmed gender. And it's important to note that most people will continue gender-affirming hormone therapy lifelong, but there's really a lack of data actually currently guiding us with what to do as people age. I think at the moment, we aim to change estradiol to transdermal formulations until further data is available. And we still have a few prospective controlled studies evaluating three-dimensional bone density, as well as changes in body composition, and we'll hopefully be able to share that data over the next few years. Thank you very much.
Thank you very much, Dr. Nolan, for that very in-depth discussion on transgender health and its impact on menopause. So now we go to our second speaker. Dr. Zedrix Galito is a reproductive medicine specialist and is the incoming PRO of our society. He's also co-chair of the Project on Sexual and Gender Minorities of the Philippine Obstetrical and Gynecological Society. He's the section head of the Reproductive Endocrinology and Infertility section of Jose Reyes Memorial Medical Center and the Los Santos Medical Center. He also had his Master's of Science in Bioethics and is a candidate for that master's degree at the University of the Philippines, Diliman. So to discuss with us the challenges on the care of the midlife gender diverse population, let us all welcome Dr. Zed Galito.
Good day, everyone. Thank you for the introduction, Dr. Banel Silao. So my task for today is to give a background, to give context on why we should be talking about transgender and gender diverse population and the issues that happen during menopause. And in this talk, we will attempt to answer 5 questions. And by answering these 5 questions, we should be able to provide a perspective and rationale on why we should be discussing this topic. The first question is, how do transgender and gender diverse individuals perceive menopause? So Dr. Nolan actually presented one paper already depicting the attitudes of members of this community towards menopause. But we will talk about first on how cisgendered women what the attitudes of these women are. So we are familiar with the experiences of cisgender women. We frequently encounter them in our clinics. And in a survey of more than 3,000 women by Tariq et al., majority of postmenopausal women report a decrease in the quality of life and sexual well-being, and how these changes impact the other areas of their lives, including work. And these women report mixed responses to the cessation of menses, with the majority expressing a relief from the burden of periods, but also expressing negative attitudes about aging and the loss of identity and fertility. And this is in contrast with the population of people who belong to the LGBT group. In contrast, the study of Mohammed and Hunter, this was shown already by Dr. Nolan, showed that individuals belonging to the LGBT plus population have a tendency to be dismissive when it comes to the issue of menopause. They, however, maintain that gender-affirming hormone therapy positively affects the overall body satisfaction and supports their identity, but they do raise concerns about the uncertainties in long-term use and access. So we do acknowledge that we know very little in terms of the safety and if there's a need to change those for those who are receiving gender-affirming hormone therapy around this age. Particular to the transgender and the non-binary group, the term menopause may be confusing. This is given that this group, there's diverse gender identities and also different contexts of hormonal change. For example, in some transgender men, the experience of hormonal change is a move towards masculinity. Therefore, this is a welcome change. And some may actually consider this as puberty, male puberty at that. For the non-binary and gender diverse individuals, hormonal changes do not align with the normal accounts of puberty and menopause. Therefore, this is not comparable with what usually is experienced by those going through puberty and menopause. Why? Because they have a different goal. Okay, for the non-binary group and the gender diverse group, they do not wish to have the same cis gender levels of hormones. They do not wish to have the same anatomic changes or the developments that you should see in cisgender individuals. And likewise, in some transgender women, they may experience menopause-related symptoms associated with changing the hormone dosage. Okay? For example, a transgender woman receiving estradiol for whatever reason will need to change and decrease the dose of estradiol. That decrease in the dosage might actually manifest as the usual symptoms of menopause in cisgendered women like hot flushes. And these changes, because of the concept of menopause as a conventionally cisgender woman's experience, result to varying responses ranging from supporting to challenging a transgender individual's female identity. Now, the second question is, why is the TGD experience unique? Okay, we should keep in mind that the experience of menopause and its related symptoms are not limited to cis women. The changes affect all sexualities of cis women, regardless of sexual orientation, be it heterosexual, bisexual, pansexual, lesbian, or gay. And for the transgender women, shifting to lower doses of estrogen, and for people with a uterus and at least one ovary, they may all experience symptoms and changes related to those experienced by women, cisgender women going through menopause, including cognitive changes, skin changes, even hot flushes. Now, owing to its relatively new development and the prevailing heteronormative understandings of menopause, there exists a significant gap in information on LGBTQ menopause health, which results to significant health disparities for the minority group. Now, to understand better why such disparities exist, we should be familiar with the concept of minority stress. Okay, now what is this? This is an excess in social stress experienced by a minority group, including the transgender and the gender diverse individuals, which is rooted to prejudice and stigma. And the general stressors, okay, so these conditions are experienced generally by all, including social isolation, financial hardships, chronic illness or disability. On top of these general stressors, members of the minority group may also experience unique stressors like discrimination in healthcare, a learned expectation for bias, prejudice towards self-identifying TGD people, and internalized transphobia. All of this will influence the health experiences of the minority. And be mindful that the minority group has experienced marginalization and discrimination from various institutions throughout their life course. They've experienced discrimination at home, in the school, at church, and even in the healthcare setting. The resulting general sentiment of dissatisfaction can be traced to the experienced internalized homophobia and discrimination. And this is a relevant aspect of a transgender individual's history that a physician should always consider. Okay, so it's part of our responsibility to really understand the patient. Okay, whatever the complaint is. And furthermore, the influence of a person's SOGI, SE, okay, so that's sexual orientation, gender identity and expression, and sex characteristics. This is often overlooked, along with the effect of learned fears from previous encounters with healthcare providers and the lack of trans medical competence that ultimately result in negative attitude of transgender and gender diverse individuals towards medical care. We have to admit, we know very little about this. Okay, there is a large knowledge gap. Okay, and locally the experience is, this is a report from SAGE and different advocacy rights group. They highlight the declining health of older LGBTI people, which is associated with sociocultural and economic issues. And one of the stated reasons why LGBT, older individuals do not or delay or outright do not go to their doctors is because they fear of discrimination by healthcare providers. And scientific fora like this, continuing medical education by the healthcare providers, this is a very good start actually. This is just one of the steps to remedy the health disparities experienced by our clients. The third question is, what is successful aging in the TGD population? Is it the same as the cisgender women? Okay. Now, health period is an important determinant of successful aging. Okay. And successful aging may be defined as having low probability of disease and disability, as having high physical and cognitive functioning, and if there's active engagement with life. Okay? But for individuals who belong to the sexual and gender minority group, there are those who report successful aging even when faced with significant health problems. And the reverse is true. Okay? While there are some healthy, older, transgender, and gender diverse individuals who report that they are not particularly happy or satisfied with aging. This emphasizes that for them, successful aging is not a mere lack of disease or disability. And for the transgender and gender diverse, they place a premium on subjective experiences of the following: feeling confident with their physical appearance and accomplishments, receiving affirmation and maintaining supportive social relationships, and having security of resources, including finances, and thriving despite their negative past experiences. That is resilience. And this is a very good conceptual framework developed by Sloan and Benson that comprehensively represents the definitions of successful aging in the transgender and gender diverse individuals. So successful transgender aging includes the following: being able to physically express one's authentic gender through the transition process, be it social, medical, or surgical, the release of shame associated with the gender minority status, and thirdly, perseverance after experiencing a great deal of trauma, stigma, and hiding one's authentic self. So that is resilience. Now, physical activities, leisure activities, substance non-abuse or non-use, employment, income, they all positively influence a transgender individual's physical and mental health quality. But due to the history of abuse and discrimination within their own family, their own houses, and in other settings, the presence of social support and the size of network, including the chosen family, is given particular importance, given value by members of the minority group because they promote the quality of life of this population. Contrastingly, avoidance or delay of healthcare among transgender and gender diverse individuals begin with the provider's heteronormative and anti-transgender assumptions. So we should be familiar, we should examine ourselves if we have biases uh, that will negatively impact how we deliver care to our patients. These biases are manifested by poor encounters with providers, lack of medical competence and inclusivity in the clinics, and hesitancy in disclosing one's gender identity. Imagine a transgender person hesitating or having discomfort in disclosing that he or she is a transgender or whatever the gender identity is. Why? Because they fear that they will be judged, they will be treated differently. Ultimately, all of this can lead to healthcare avoidance or delay. The fourth question we want to answer is, what are the responsibilities of the healthcare provider? So now that we understand what our clients are going through, what should we do? Okay, and currently, there is lack in distinct clinical guidance on how to approach older TGD clients. In fact, there is lack of guidance in the care of TGD in general. Okay, we have available treatment or approach guidelines, but this is limited. Um, for example, in the Philippines, we don't have local guidelines yet, but the good news is it's being developed already. Okay, the PPAT is already working on it. Most available researches and information on menopause apply particularly to cisgender white women. What we know so far about menopause is applicable basically is based on the knowledge and the experiences of white cisgender women. Now we extrapolate what we've known and then we apply this to other populations. But admittedly, this is difficult to apply in our transgender and gender diverse patients. A holistic approach to midlife care of transgender individuals should prove beneficial. And we can start by creating a gender or a transgender and gender diverse affirmative environment. We call this the safe space. This is a welcoming, inclusive space which should encourage a healthy relationship between the physician and the client. We should pay particular attention, for example, to the intake or registration forms that we use in our clinics to avoid gender binary language. We should use the preferred language, the preferred names, and pronouns of our clients. And we should try to avoid heteronormative languages. These are just some of the examples. However, even though we have our biases, even though we know our inadequacies, we are not hopeless as healthcare providers. Our own inadequacies and biases can be improved by observing gender sensitivity, being aware of minority stress, by practicing cultural humility, and by exhausting means to improve our gaps in knowledge. As care providers, we owe it to our clients to be better at what we do and to remedy the unmet needs of our disadvantaged group of patients. Now, we move on to the last part of this discussion. Are there ethical concerns? Are there ethical issues that we should be aware of? And the right to health is basic and inherent regardless of the background, regardless of the sexual orientation or gender identity of an individual. We know this already. Okay, yet health disparities exist, particularly in our elderly, our older transgender and gender diverse patients. They are experiencing triple discrimination. Why is this? That's threefold discrimination from transphobia, homophobia, and ageism. So it's like it's like being a disadvantaged group within another already disadvantaged group. Now, if we apply the basic bioethical principles of autonomy, beneficence, non-maleficence, and justice, patient's autonomy is consistent with respecting a person's bodily autonomy. This is by assisting in their transition journeys, including at midlife. Believe me, there are patients who will decide to proceed with transition only around this age because they've already freed themselves of the responsibilities to other people. Okay, it's their me time. Okay, time for them to move to try to achieve what they've always wanted to. And by assisting our patients, that is respecting their bodily autonomy. Okay, and that promotes self-determination. Also, we should facilitate access to gender-affirming care, which has been proven to improve the individual's mental health and psychosocial functioning. Granted that not all of us are familiar with the proper care, the administration or prescription of hormones to our patients. Let's admit it, this is a new branch of medicine. Okay, so granted that we as providers will not be confident and proficient in transgender care, there will always be a group of experts or centers that can cater to our patients if only we can direct them to these centers and experts. So it is our obligation to be familiar with um, these experts who can help our clients. Better yet, this need should be our motivation to learn more about the topic. Okay, this branch of medicine was not taught to us in med school. Okay, um, Currently, this is being introduced in the curriculum of the med students, yet we know very little about this topic. And due to the uncertainties in gender-affirming care, including hormone therapy, some providers may be hesitant or uncomfortable with assisting patients. However, the presence of risk is not by itself enough to justify denying treatment. In fact, there are risks also involved or associated with non-treatment. And financial constraint is a barrier to just access and gender-affirming care. Health insurance companies should be encouraged to be more inclusive. And as us being sworn promoters of health, it is our responsibility and our duty to take down barriers and to allow our clients access to due and just healthcare. So just to review the key messages of this very short talk, menopause is not limited to cisgender women. The experience of menopause in the transgender and gender diverse individuals is diverse. There is a huge knowledge gap in TGD healthcare, and we should be familiar, we should recognize that minority stress contributes to the negative health outcomes of our clients. Successful aging is not limited to physical and biological health, but also particularly to our transgender and gender diverse individuals, clients. Subjective experience is very important, and TGT affirmative healthcare promotes successful aging. We are not hopeless. We have our biases, we have our limitations, but cultural shifts and educations can promote health outcomes. And competent transgender and gender diverse healthcare is consistent with the basic bioethical principles. And that's my last slide. Thank you very much for your attention.
Thank you very much, Dr. Galito. That was really an enlightening discussion on the challenges that our transgender diverse patients are encountering. So now we move on to the question and answer part. There are a few questions here in the chat box. So the first question is, I think I'll ask this first question first. What are the psychological impacts of transitioning, and how can mental health services be integrated into the gender affirming care? Dr. Nolan, would you like to answer this?
Sure. So I think there's an emerging body of literature, firstly showing the significant benefits on many mental health outcomes for trans people, with respect to improvements in depression, reductions in suicidality, improvements in quality of life, as well as improvements in gender dysphoria. So certainly we've previously published a randomized trial in which we randomized people to immediate initiation of testosterone, so transgender men, compared to a cohort of people who initiated in 12 weeks, which is a standard wait time in our clinic. And in that 3-month period, we reported clinically significant improvements in depression and a 50% reduction in thoughts of suicidality or self-harm. So I think the benefits of gender-affirming hormone therapy can't be understated. But it's also important to acknowledge, I guess, as we've both discussed tonight, that there are several other factors that are obviously very important to someone's mental health. And there's often external factors through discrimination or other aspects of one's life that often do have a significant impact on mental health. And so I recommend to all of my patients that they have mental health clinician input. So most commonly a clinical psychologist or a counselor as someone that they can liaise with during this process of time. It's not mandated in our clinics unless people are under the age of 18, but certainly in adult populations, we still recommend engaging with mental health clinicians during this, what can be a difficult time for some people as well.
Thank you, Dr. Nolan. Another question, I think Dr. Galito can answer this. How do we ensure equitable access to gender-affirming care, particularly in underserved or rural areas? That's a tough question.
Yes, it is a tough question. And we have to admit that the national insurance system does not cover for hormones that should be used by patients in transitioning. Even some of the private health insurance companies will not cover this. There are some generous health insurance companies that do cover partially the cost of the hormones being used by our patients. The good news is there are some free centers that are being established right now. So those who are affiliated with the government hospitals, they are putting up centers. I don't know if they've already functional or if they're receiving patients right now, but that is the goal. To include this maybe in we should lobby and make this part or be covered by the health insurance system, be it public or government. That's one way to promote equity in access to transgender hormone medicine.
Thank you, Dr. Galito. Another question is, among the trans men in your patient population, what percentage underwent surgery aside from using gender-affirming hormone therapy? And does this subgroup have any special post-surgery needs or issues? This is for Dr. Nolan.
Yeah, so a lot of our patients desire gender-affirming surgeries. Within Australia, we're lucky in that our healthcare services are covered by the government. So for a lot of our outpatient clinic consultations, there are no out-of-pocket fees in our public hospital system. And all of the medications, so testosterone and most of the estradiol formulations are also have a co-payment from the government so that they're all subsidized as they are for menopausal hormone therapy. One of the issues that we're facing at the moment is that there are barriers to care for people who desire surgery because they are all done by what we would consider a private provider, so not through a government hospital. And as such, there's significant out-of-pocket fees associated with that. So a lot of the time, it's not necessarily that our patients don't want it, it's that they don't have the financial means to have surgery. That being said, top surgery in transgender men, so removal of breast tissue or bilateral mastectomy, is by far the most commonly performed procedure in Australia. I would say nearly all, at least 90% of our patients want it. And it's just really about the, I guess, equity as we were just discussing. Bottom surgery, so phalloplasty, so creation of a penis, is much less commonly requested. It's obviously a much more involved procedure. And in Australia, nationwide, we have one surgeon who offers the procedure. So it's not something that's commonly done. As for the question regarding, I guess, post-operative care, I guess for people on testosterone from their hormone perspective, there's typically no difference in hormone prescribing. So we typically continue testosterone as we would otherwise. But they do often have quite a few post-operative appointments with the surgical team just to evaluate, obviously, scar, but it's usually just a night or two in a hospital following the procedure.
Thank you, Dr. Nolan. Another question, how does hormone therapy like testosterone affect the management of menopause symptoms in trans men? And are there specific considerations for their care compared to the cisgender women during this stage? Anybody can answer? Dr. Galito, would you like to answer?
I think Dr. Nolan is in a better position to
Yeah,
answer.
Dr. Nolan, yes.
Yeah, happy to answer the question. So typically most of our patients who would undergo what would be considered a standard menopause, who are treated with testosterone, often don't have vasomotor symptoms in most people, just from the aromatization from testosterone to estradiol. That being said, there is at least one published case report that I'm aware of in which a person did have significant vasomotor symptoms. And that person was treated with a transdermal estradiol in addition to their testosterone formulation, just to overcome the vasomotor symptoms. It's not something that I have seen in clinic, and I would suggest that the risk would be relatively low, provided that there was ongoing testosterone therapy. I guess from that perspective as well, most of our patients, it's very rare for our patients to also have an oophorectomy. So I'm not sure if that cohort of people would potentially be at a higher risk, as it's not really a procedure that we very commonly do in Australia.
Thank you for that answer. There's a comment here from Ramon. The topic is very timely. I think we practitioners should not be judgmental. If you are not confident enough to handle such, refer to someone who can handle it so as not to add burden to the patient. Again, thanks a lot to the speakers and the moderator, hoping for more related webinars like this. So thank you very much for that comment. I have a question, Dr. Nolan. Have you come across the risk of breast cancer for trans women on estradiol or estrogen therapy?
Yeah, definitely. So for trans women, really the only data or the best data we have again is a large cohort study from the Netherlands, from their clinic there. And they again had a group of trans women established on gender-affirming hormone therapy and compared to matched cisgender male and female controls. And in that cohort, they found that the rates of breast cancer in that cohort were higher than that of the cisgender men, but lower than that of the cisgender female population. Yeah. So I think there's definitely an increase in risk. Obviously, part of that is probably going to be dependent on the duration of estradiol therapy as well. And so typically our recommendations are to undertake breast cancer screening with mammography, as we would in the general female population.
Usual,
yeah.
Thank you for that answer. I have another question. You mentioned about the serum estradiol level because if too high, sometimes it's bad for the bone health, right? So as they age, Dr. Nolan, do we have another monitoring of what estradiol level would be nice so that to minimize that they get the benefit of still that bone health?
Yeah, so I think in the longitudinal studies, the people who have the greatest loss of bone are those with the lowest estradiol concentration. So again, typically it was the lowest tertile, so that was lower than 182 picomole per liter.
Yeah.
There's no real target otherwise that we aim for. And I guess really it comes down to an individualized decision with each patient. And I mean, ultimately, some of my trans women have indicated that they actually might stop their feminizing hormone therapy later in life, as that is what the serum estradiol concentrations will happen in a cisgender woman at menopause. And so I counsel people regarding that risk, particularly with respect to vasomotor symptoms, particularly if they also have suppressed or undetectable testosterone concentrations, and counsel regarding the risk of really, I guess one of the big questions in trans health literature at the moment is regarding optimal estradiol concentrations for anything, whether it be feminization, cardiovascular disease risk, bone health. So hopefully we'll be able to answer the question very differently in 5 to 10 years, perhaps.
Yeah. A lot of new information for us. Another question here is, how can society balance the ethical responsibility to respect transgender individuals' rights and identities with concerns about the potential impact of gender-affirming medical intervention on minors? I think Dr. Galito, this is for you.
Yes. Of course, we need to recognize, and this is evidence based already, that even among minors, those who've been diagnosed with gender dysphoria, there is significant improvement in the mental health of these individuals if they go through or receive gender affirming care, not necessarily hormone therapy. It's not always that. Even social transitioning is one way of improving gender dysphoria already. Um, so we should be aware that there might be harm as well if we withhold treatment. So if these individuals, even young, would require hormones that will help them align the identity with the bodies, that will make them feel complete or whole, that will improve the life of these individuals in general, um, then they should be allowed to receive those treatments. These are considered necessary. These are considered now essential for these specific cases. And be aware that if we withhold treatment to these individuals, there could actually be harm if they do not receive the treatment that they warrant. Okay? For example, those who fail to transition or receive medications for transitioning, for whatever reason, cost, no access, they remain subjects to discrimination, to victimization, because they were not able to realize their actual selves, their authentic selves. So they remain vulnerable, and so we need to balance that the possible risks with associated with treatment, but there's also the set of risk associated with non-treatment. So that's just one of the many issues that we should be talking about.
I think it's more complicated for like what Dr. Nolan said when to minors or to the
Yes.
very young. Like so I actually I was surprised, Dr. Nolan, that the psychological counseling is not a must, right? You mentioned that. So for if they really want to transition, it's not a requirement. In our country, really, we're just starting. So there are only a few
Mhm.
centers. That's why it would be nice to invite you to our annual convention next year so we can have a more in-depth discussion about this very interesting case. I think we have answered all the questions. Before we end this webinar, may I ask for some parting words? What are your uh, final messages, Dr. Nolan?
Yeah, I think final message would be I see the benefits of providing affirming care pretty much every day in my career. But ultimately, we don't have enough practitioners who are able to perform gender affirming care. I started working in this space in 2019, and during my endocrinology training, I had not seen any transgender people for gender affirming hormone therapy until I finished my endocrine training. And so in the past 5 years, I probably have seen between 2 and 3,000 trans people. And I think it's important really to, if you're not sure what to do, acknowledge that you do have some limitations in previous experience, but also it's really about being affirming. Using the person's preferred name and pronouns. And if you feel comfortable, you have to start somewhere. And if you don't feel comfortable, obviously just being aware of who to refer to, because there are significant benefits in providing gender affirming care.
Very well said, Dr. Nolan. Dr. Galito, any final words?
Yeah. Actually, I have the same message as Dr. Nolan's. Um, we are not expected to know everything. This is a fairly new development in medicine, and just be welcoming. Try to be as inclusive as you can, and strive hard to work on to work on our inadequacies, on the knowledge gap. There's a lot of room for improvement for everyone. Okay, so that should be our objective, to be competent in providing care to the members of the sexual and gender minority group.
Agree. And Dr. Nolan, if you have like webinars, future webinars, or lectures that maybe you can post them in IMS or wherever we can reach you, so we can have more learnings. Okay. So thank you very much again. It's such a pleasure to have both of you. I've learned so much. And just to remind again our audience that this webinar is recorded, and we will have the recorded version available in the IMS website or in the YouTube channel. So you can, for those who got in late, or those those who would like to review the slides that they posted, then you can always go back to the recording. I think this is the last webinar of the CAMS Menopause Hour for this year, and I hope that we all learn from this, and we wish you all a pleasant day, and we look forward to more activities from IMS CAMS in 2025. Thank you very much. That ends our session.